Talking about this can be difficult, so let's us acknowledge that we're entering a sacred space together, and we'll listen and raise our hands. There are buttons at the bottom that you can raise your hand, um, but wait till the question and answer time. So in the meantime, just mute yourself and listen. And I should introduce myself. I'm Susan Robinson. I'm president of the Oregon Memorial Association Board. We are 65 years old this year, that is, the association is, and it has helped thousands of Oregonians to plan dignified and affordable body dispositions. But our primary goal is to educate people about their end-of-life choices and their rights as funeral consumers. And to this end, we speak to any group that will invite us. And volunteers conduct our own Oregon-specific training we've referred to a little bit in our pre-session conversation. It is called All's Well That Ends Well. We share it at least 8 times a year. Some sessions are in person and some are on Zoom. The next workshop will be virtual. It will be at 6:30 on Thursday, February 12th, and you can sign up for it on our website. We'll mail you the workshop materials a week or so before. With about 7,000 members around the state and in Southwest Washington, we are proud to still answer the phone and provide resources to the public and our members alike. We're always lucky to have good speakers on a variety of end-of-life topics. And so I'm really pleased tonight to introduce our speaker who works with a private nonprofit hospice that happened to serve both of my parents in the Corvallis area and helped our family enormously. Molly Gage joined Lumina Hospice and Palliative Care in February 2024 and then became the social services clinical manager in August of 2024. She has 15 years combined experience as a hospice and palliative care social worker. She holds a BA from St. John's College, the Great Books Program, and an MSW from Portland State University. She lives with her family in rural Oregon, west of Corvallis. Molly, you have the floor.
Thank you, Susan. And thank you all for being here, and thank you for inviting me to speak. I very much appreciate it, and appreciate I don't have to talk any more about myself. Thank you for the introduction. I just get to talk about hospice. So I'm going to share my screen, and does that work for everybody? Does that look good? Very nice. Okay.
Yes.
So the topics I'm hoping to cover are: what is hospice? When does someone come on to hospice? How does someone come on to hospice? How does hospice work? Um, and all related related sorts of questions. And my slides are not, yeah, doing what they did when I tested this.
Always the way.
Okay, I think I found it. Okay, so hospice is end of life care. It's designed to give supportive care to people and their people at the final stage of a terminal illness. Our focus is comfort and quality of care, and we're not looking for a cure. And the goal is to enable patients to be comfortable so that they can live each day as fully as possible. We provide what we call holistic care, which is the whole person, looking at people's emotional, social, and spiritual needs in addition to their medical needs. And our unit of care is the patient and their families and caregivers. And care is provided wherever somebody calls home. The concept of hospice has been around a long time. The word was first used in the 4th to 11th century, around about there, for places that people on people who are traveling could rest, and that included the sick and dying, and those were often run by religious orders. And the first institution specifically for end-of-life care was opened in France in 1842. What hospice looks like now was started by Dame Cicely Saunders in London in 1967, and the first U.S. hospice was opened in 1974. We really gained credibility with the founding of the National Hospice Association, or organization, which is now called the National Hospice and Palliative Care Organization, and the Medicare Hospice Benefit. Much of our funding comes from Medicare, and Medicare guidelines tell us everything that we need to do, which I'll get into shortly. So hospice as it is now was really started in the 80s here in I mean, it started before that, but it really became broadly known and broadly used in the 80s in time for the AIDS epidemic. And that's when people really started to hear about hospice. So our core beliefs are dignity at the end of life and patient autonomy and choice. And what I mean by that is patient-centered care. We're focused on our patients' values, on their wishes, on their goals. We get to know them as people. So all of our care is very personalized. And everybody's care is a little bit different based on who they are and what they want, and their circumstances. We're focused on quality of life rather than extending life. So we often say we're neither hastening nor postponing death. We're keeping you comfortable as death comes in its natural course. I've already said that holistic care is provided by an interdisciplinary team, which I'll get to, and our support is for everyone involved in the patient's process, both while they're still with us and afterwards. And we believe that death is a natural part of life. So, unlike many places in this culture, we're talking about death all the time. Hospice care is provided in the patient's home, wherever that may be. So some patients are at their own home, and some are in facilities or residential care of some kind. There are hospice houses. I think there are only 3 right now in Oregon. And there are very specific criteria for why people go to hospice houses. Hospice is primarily an in-home service. So we're going to you or whoever we're serving. The 2 criteria for being eligible for hospice care are, one, that you have a prognosis of 6 months or less, and that's determined by a physician, ultimately by our hospice physician, but other physicians will sort of get the process started by saying, I think your prognosis is 6 months or less. I'm recommending that you look into hospice. And that's there are different guidelines for each specific disease that will tell a physician that they can tick the boxes that somebody appears eligible. Sometimes there are comorbidities. More than one disease is affecting the patient's life. And sometimes people don't have a terminal disease, but it's very clear that they're working towards the end of their life, that their body's shutting down. And there are various things that we're looking for there, which is functional decline, and perhaps they're not eating and drinking anymore. That one is quite obvious. But we're trying to determine whether somebody's going to live 6 months or less. I call that a rolling 6 months, because it doesn't mean you can only be on hospice for 6 months and then you'll be kicked off. It means that at any given time, the physician's saying, yes, I think you have 6 months or less to live. And there are periods that are built into the Medicare regulations where we look at that, and recertify that the person has 6 months or less to live. So that's the first eligibility requirement. The second is that their goals are in line with comfort care and no longer seeking curative treatment. So hospice is going to provide all of their medical care, and they won't be going to the hospital any longer. They won't be going to see specialists any longer. If they've chosen their primary physician as their attending physician, then they can continue to see their primary physician. And a lot of people do because they've established a long-term relationship with that person. And so they can continue to see their primary care physician, but otherwise they're not trying to cure their disease in any way. Um, Care is covered by Medicare and other private insurance, the cost of care. Some hospices provide charity care for patients who are uninsured and unable to pay, and we will do that. We're going to look at the circumstances, and if that's the only way that we can provide care, we do. Um, Medicare guidelines really tell all of the hospices in the country what they're supposed to provide, how frequently we're supposed to see our patients, what we'll be paying for, which is ultimately what Medicare pays for, and some of the things that are in that package are physician visits. I have to say, my hospice Lumina is rare in that our medical director visits every patient when they first admit. I've worked for 4 hospices now and not seen that before. Um, I've seen physicians visit when there's a face-to-face visit needed, which means are they still eligible, or there are other guidelines determining that. But to have a physician regularly visit every patient is really rare, and will stand out if a hospice is doing that. Um, every hospice provides 24-hour nursing availability and a full interdisciplinary team. We provide all of the medical equipment that's needed, all of the medications that are related to the terminal illness and comfort care. And it's important to say that patients have the right to choose whatever hospice they want to choose. Sometimes a residential facility or a hospital may downplay that and say you have to sign up with a certain hospice, and that's absolutely not true. Patients can choose, patients and families can choose whatever hospice they want to. Um, So it's also important when people sign on to hospice and are choosing hospice that they know what hospice isn't. And we're not caregivers. We don't stay for a period of time and provide personal care. We don't provide room and board. We're not primary care physicians. And we're not providing services or medications or supplies that are not related to the terminal illness. If somebody does, which are all of our patients do who are on Medicare, which is really 90-some% of our patients, do say that Medicare will pay for hospice care if they have services not related to their terminal illness. I like to use the example of a dog bite. There's no question that that's related to their terminal illness. Medicare will pay for that, or Medicare or their private insurance will pay for that as they always have. But hospice takes over medical care for people pretty much completely. And we're not providing treatment. We're not looking for a cure. Any questions at this point? Okay. Uh-huh. I heard a ding. Oh.
Do some hospitals also have an associated hospice?
Yes, they may have an associated hospice. If they're in a hospital system, in a healthcare system, let's say Kaiser or here Samaritan, they may also have a hospice that works under the same system, yes. But patients aren't required to choose that hospice. That's where the messaging doesn't always get out in a hospital that's affiliated with a certain hospice.
Having been with it for a while, does it seem to you that the state and federal regulations regarding hospice are pretty appropriate?
That is a long conversation, but the easy answer is yes, I do, actually. I think that our hospices now are so structured to meet the Medicare guidelines that it's really helpful to have that across the board structure and to know what a hospice in North Carolina, the basic structure of what they're going to do to know that it's similar to what we do here in Oregon.
Mhm.
Um, and whether they're the right whether it's the right structure, I'm going to say primarily yes. It's really um, focused in the same way we are.
That's very reassuring. Yes. Thank you.
Uh-huh. And that's the short answer, but yes. There's someone who's not muted, I'm hearing. Um, so I talked about the hospice team, and we're all the circles on the outside. The patient is our primary person that we're caring for, and we're also caring very closely for their friends and family and caregivers. And then the people on the team, I don't know if you can see my pointer as I go around. Like I said, the physician is overseeing all of the medications. Every hospice, based on Medicare guidelines, is meeting every 2 weeks well, we're meeting weekly, but speaking about each patient every 2 weeks. So if the physician isn't getting updates between that time, that's our time to update the physicians and each other of any changes. If something's needed, we wouldn't wait 2 weeks to get them involved. We have physicians on call 24 hours as well, who are going to put in an order for a new medication if it's needed or that sort of thing. So we're small enough that our physicians are very aware of the situation of every patient that we're serving. Every patient is assigned a nurse case manager. They have a caseload of between 12 and 15 patients usually. Their um, their standard is to see people twice a week. Um, and then at the end of life, at the very end of life, the last 5 days of life, if we can predict that, we're trying to see people daily. If anybody's in a crisis of any kind, we may be seeing them daily. Or some people say, hey, I'm fine right now. I don't need to see you as often. And the Medicare minimum for the nurse case manager seeing the patient is every 2 weeks. So they're in the home the most frequently. Um, all patients are also assigned a social worker. Our caseloads are more like in the mm, high 20s, mid 20s. And we also our visit frequency is however often people want to see us. Our standard is more like every 2 weeks. If people say, I don't want to see you very often, we're talking about the same things every time, or, um, everything's stable and they have the supports they need within their natural system. And they really aren't needing a social worker right now. We meet them more like monthly. And as a social worker in those situations, I say, if you don't need anything from me right now, can I visit you every 2 weeks or every month just so that we can get to know each other? Because then if something comes up, you'll already know me, you'll already trust me, I'll know a lot about you, and I may see things also that I can suggest would be helpful. So we're establishing a relationship. But what the social workers, our realm is generally emotional support and resources. So that can vary anywhere from counseling about people's fears of death or anxieties or um, depressions or hopes, wishes. We do a lot of family mediation if that's needed. Um, will so sort of the counseling realm, and something that I also really like to emphasize as a social worker, and that's particularly with people who say, well, I don't think I need a counselor. um, would you like to tell me about your life? And that becomes more than reminiscence. It becomes, wow, these were turning points. And let me think about who I was before some particular thing happened and after. And has people, if we're, if it's going well, and I love it when somebody says, I never thought of it that way before, that those sorts of touchstones make that process seem, well, sort of validate to me that that is a very valuable process. It's more than telling stories, doing life review. So that's something else that we do. In the resource realm, we're providing resources like, here's the local veterans office, and here's why you should connect with them. Or, gosh, I'm not able to provide care at home anymore. What do we do? How do we do it? Where do we look? What's the process? And um, how do we make those calls? What questions do we ask if we need to make that kind of change? Meals on Wheels, all the sort of basic resources we're connecting people to. Um, so it's a very broad realm, and that's why it's been interesting to me all these years, because it's always different. And another thing, visiting patients who are nonverbal or perhaps in memory care. We're providing socialization and dignity, and um, we're going and we're paying attention, and families say they appreciate the frequency that the social worker, the chaplain, the volunteer, people are going just to spend time with people who may not get a whole lot of visiting time. And so we're meeting everybody as where they are, and the social work adage, and providing all sorts of different things. Our chaplain, moving around the circle again, our chaplain can overlap with the social worker some, but they're focused on what we call spiritual care, and that can be a broad range. They're non-denominational, so they're not pushing religion, they're not pushing any particular kind of religion. We're defining spiritual care as helping people explore meaning, helping people explore their values, helping them work through those sticky points of regrets or things that they're needing to express at this period of time. And so our chaplain is visiting to again, um, it's different with everybody, but visiting for emotional support, socialization, and helping people hone in on some of those questions. Um, Physical therapy we do by contract, and that's not to get better, but it's usually more like in hospice, it's usually more like a one-time visit to train caregivers how to do safe transfers or something like that. Um, the hospice aide is also, if needed, visiting maybe twice a week to provide personal care like showers. And so they develop very intimate relationships with our patients and are really important to our team. Um, I'm going to skip bereavement counselor and come back. We have at Lumina over 100 volunteers. Tonight we had a presentation for people who are interested in becoming volunteers. It looked like a big crowd. So we have a really robust volunteer crew here, and they do all sorts of things. They also provide friendly visits if people are lonely. They provide respite for caregivers. If the caregiver wants to go shopping or turn off and take a nap, walk the dog, kind of take care of themselves or has an appointment. We can provide a volunteer and some of our volunteers are trained to provide help with personal care a little bit while somebody's away. Um, so respite, we have vigil volunteers who sit with patients who uh, may otherwise die with someone, not die alone. So we're providing, sorry, a rotating crew of volunteers who are doing that, sitting with them around the clock. We have pet therapy, we have Reiki, we have musicians, we have a local choir called the Threshold Singers who are singing at bedside when people are dying. People can do errands, chores. We have volunteers who work in the office. We have volunteers who co-facilitate some of our support groups. So we're really lucky in our volunteer crew, and they're skilled volunteers also. We have retired nurses, we have retired counselors, we have writers. So we're trying to give them jobs where they're really valued by us to have them involved and also are getting job satisfaction. Um, and let's see. So, and then our bereavement counselor, is that my next slide? No. Um, so I will tell you on another slide what our bereavement services look like, but our bereavement counselor is sort of heading up all of our bereavement services, and I'll get to that on a future slide. Um, Good place to stop for any questions since I spent a long time on this slide. Okay, so what are some of the common symptoms that we're treating at the end of or addressing at the end of life? Medical symptoms, we're frequently seeing our pain, shortness of breath, anxiety, hallucinations, and non-medical symptoms like depression, anxiety, unfinished business, relationship stressors, spiritual distress. So somebody on our team is trained to deal with all of these things. We're providing education all throughout care for the patient, for their family, for their caregivers, and for each other. So some of the education topics like open discussion about what to expect from the dying process. We're teaching caregivers because most of our caregivers are family members. The majority, we work with a lot of professional caregivers as well, but hospice is a time where family members who have not been caregivers are working as caregivers and they've never done it before. And it's a big change for their own life, and we're also helping them feel confident to be caregivers. So while we're not caregivers, the hospice team, we're educating and empowering families to be caregivers. Um, we're talking to people about their post forms and a do not resuscitate order, um, and helping people decide what their decisions are about that. We're talking about the role of food and drink at the end of life. At the end of life, people get to a point where they don't need food and drink, and that's really difficult for families because food is life and food is comfort, and to say that people don't need to eat any longer at a certain point because their organs are shutting down, that's a big shift. Um, and so we're talking about that a lot. We're helping people plan their final arrangements. We're talking about anticipatory grief, which is grieving that starts while the person is still alive for all of the losses that come with this whole process and for all of the might have beens. Um, it so that's something that we talk about a lot. We work with a lot of patients with dementia, and so education about what to expect next, how to communicate effectively or communicate love, communicate feelings with fewer words, um, how to be with people without having it be all about words and conversations. And remember, oh, sorry, that was a bad question. And so we do a lot of dementia education. Our physicians are often working with polypharmacy. We see people come in with just a huge list of medications that they've just been adding to over the years, and that haven't been reduced. And so one of the first things we're looking at is, do you need all the medications that you're taking? And also, do you want all the medications that you're taking? Um, so that's something that we're doing on a constant basis. Any questions on that slide? So this is a social work slide. Dr. Ira Byock is a very well-known hospice physician and has written some really lovely books. And this is from one of his books. He calls it the 5 things of relationship completion. And I'll often share these phrases with patients and not identify that I think they need to do anything, but just say, in order to close close things up with people, in order to find some resolution, in order to feel as though you're ready to die, it's often relationships that people are thinking about and letting go. And so these are great things to say to the people around you. And it also helps people who are left behind to say nothing was left unsaid. So, so these are great conversations to have, and I'll tell patients and families that. Um, and I'll say it just like that so that I'm not guiding them in any particular way. I'll say, hey, these are 5 things that this hospice doctor has said are good to think about and talk to your people about. Please forgive me. I forgive you. Thank you. I love you, and goodbye. And usually if I say that, and I don't say it to everybody, but I bring it up sometimes, they'll say, "Oh, yeah. Okay." And then they start to work on something or other that they're interested in healing. So those phrases are very powerful to me as a social worker, one of my tools.
Mm.
Um, Then what to expect from the dying process? I have a picture I've gone from my site here, also called the Little Blue Book, a very common reference for hospice. and it's this book is a guideline through the dying process to say what to expect. And it's presented in a very comforting way. And when I think about what to expect, I think about this book, which I'll often say to people, pull out the book that's in your hospice binder and let's look at that. And that's why I put that picture there. So, what to expect? Physical changes in the months to weeks before death. You'll see people having less energy, less strength, being able to do less, increased fatigue, more sleep, more rest, reduced appetite, weight loss, worsening symptoms of their chronic illness. So let's say they're on for a respiratory disease, you'll see that they're struggling to breathe more in circumstances where that wasn't the case before. And what we see emotionally and cognitively is people reflecting on their life and what I call it, what was that all about? That's what I like. If people are looking at their life from towards the end, I think about it as a full, I often use a book metaphor, a full beginning, middle, and end. And now we're at the end. We haven't been there before. So now we look at your life as a whole, as opposed to you're in the process of this last stage, but all the other things are in the past. And how does that um, change people's perspective? Um, Emotional sensitivity, we'll see that people are, I guess I describe that as having a thinner skin than they normally would have if they're sensitive. And this can be family members as well as patients. Um, and often, they're not sleeping well sometimes either. The patient's symptoms can carry over into the caregiver. Sleep's a good example of that. Um, and calm acceptance. That's definitely an emotional state that people come to. And I guess if I have a goal with my patients, and of course we're looking at their goals rather than our goals, but I say my goal is that my patients are at peace with their dying, and sometimes that happens 6 months before they die, and sometimes it happens minutes before they die. And if that happens, then I feel like it was uh happened. I don't know. I don't like the phrase a good death, but that's sort of how I define a good death, is if the patient and the people around them at the end are accepting and at peace. That doesn't last, but it's just in that moment. We also see people withdrawing from social activities, and also from people. They're sort of um, decreasing the number of people involved in their lives to the most important, and not wanting to be social. Of course, that depends on the person. Some people um, are the opposite. um, Decreased concentration, decreased attention, desire for reassurance, familiarity, and routine. I just want to make sure I say that these are all normal things, but not everyone does all these things, and it's definitely not a linear order to these things. So that's months to weeks, and then we have final stages, days to hours. This is when the hospice team, if we see signs of this, we're visiting uh, every day. Um, we'll see minimal to no. Well, if it appears, yeah, it our sort of loose guideline is if it appears that the person's dying within 5 days, but that's not a thing that we can predict that minutely. We can predict hours before death fairly well. and days. So this is where we can predict a little bit better than as far as a timeline. We see physical changes that people aren't eating and drinking any longer, and shouldn't be. Their body can't process food and fluid any longer. That they're sleeping most of the time. They might be difficult to arouse, difficult or impossible to arouse. Very um, their breathing may change. They have cool hands and feet. Their skin tone may change, and blood is pooling at their extremities. Um, they may stop urinating or decreased urination. Um, and and this is the death itself. Breathing gradually slows and stops. Um, we see people with limited or no verbal response. We see periods, we can see periods of confusion, restlessness, and that can come along with a lot of energy, actually. Visions are speaking to people who aren't present. I love it when I can witness this. It can be very spiritual when people are sort of half here and half not here. Um, it appears that they're talking to people who have passed already and reaching out to them, and what's been really um, rewarding are times when people are in and out of that and can come back and tell you about it. It's it just provides a whole lot of comfort often. Not for everybody. Sometimes there's reasons that those visions are disruptive um and not don't feel safe. And so we're looking out for that. If that's the case, then we're going to try to provide comfort for that, either medically or non-medically. But yeah, that can go, um, yeah, that can go either way. But uh, hearing may remain until very near death. That's another adage. We say all the time, hearing is the last thing to go. And I have extra time to verge into storytelling. So I was once working with a man who had been homeless and had asked me and came in with people saying he has no family. From the hospital, we were told he had no family, but he was lucid and he told me to call his sister, and I did. And she was unable to come in because she was sick. Um, and so I was on the phone between them, and that was a longer story. I won't tell the whole big story, but I was holding the phone up for him, and the room he was in still had the television on. And there was a soap opera, and this kid said, "Did you know that people who are dying can still hear everything you say?" And meanwhile, that's happening over the phone, and it's like, oh yeah, neat. A nice little synchronicity. We see a lot of synchronicity. So there are definitely times when we've been shown that that's not a good example because that was a TV, but we've been shown that people can still hear when they're no longer able to speak or show us
Mhm.
in any way that they're hearing. People often appear restful. Um, and people can also have a surge of energy in the last few days of life. Um, if they've been waiting for a particular person to show up, they may come back and be very lively in a conversation with with that person, because it's part of their closure. So we that's definitely something that we see sometimes. And so any questions about those couple slides? I said I'd come back to bereavement support. Medicare requires that bereavement support of some kind is provided for 13 months after a death. And it's pretty standard that that includes telephone calls or mailings with information about the grieving process, the availability of bereavement counseling. Um, Most hospices have an annual memorial service for their patients. We have two, and ours are for the whole community. Um, and often bereavement support includes grief support groups. Our Lumina's bereavement support program is so robust. We have drop-in groups 3 times a month. We have an 8-week series called Grief Education and Support. We have a child and family grief support group that we've just started back this year after it stopped for the pandemic. We added a support group specific to suicide loss because we had community members coming and asking for that. And so that's become very um, strong group. We provide bereavement services not only to our hospice families, but also to the community at large. Yeah, that was just a little bit of bragging because we go over and beyond in our bereavement support. And the need is definitely there. Our drop-in groups have just gotten bigger and bigger, and now half the time we split the groups because they're just too big to have that many people have good conversations with 20 people there in the room. So we'll split the group in half. Um, so we have a lot of people involved in those groups. And this also is something that I don't know that every hospice is um, letting their families know that bereavement support is available to them. So it is part of the Medicare package, and it is something that every hospice provides um, to some level. So it's a good thing to ask about. We often get questions about what happened, and okay. What is hospice and what is palliative care? Because they're not the same thing. Um, Hospice is a subset of palliative care, but palliative care is can be a longer period of time. Um, Palliation or palliation, it's said both ways, is comfort care. It's relieving symptoms. So it's pain, nausea, shortness of breath. Um, those symptoms may come from the disease or they may come from the treatment. They may be used. Palliative care is often provided concurrently with, say, chemotherapy. The chemotherapy is battling the cancer, and palliative care is providing the treating the symptoms. So a palliative care program, we have both. We have palliative care and hospice, is um, often pre-hospice. People can still be seeking curative care. They can still go to the hospital. They can still see specialists. And we're visiting in the home and making medication recommendations. Our physician is based on what we're seeing in the home, and then consulting with their primary physician or their specialists who actually does the orders for our palliative care program, but don't have eyes on the patient as frequently as our program does. So it's working alongside their medical team. Um, and that can help our patients manage symptoms, also plan ahead. Our eyes on them in the home can help see things before they become crises, so we can prevent hospitalizations oftentimes, avoid emergency room visits. So palliative care is often there are hospices who also provide a palliative care program and see people before they're eligible for hospice. Our criteria, our eligibility criteria for palliative care is roughly 12-month prognosis. That just gives us a guideline for who's appropriate for our palliative care program. Palliative care is not a there are no Medicare guidelines for palliative care, so programs are not held to the same standards, and palliative care programs vary a whole lot more widely in what they offer and what their criteria for eligibility are than hospice programs do.
But is that paid for by Medicare?
No, it's not. It's not. So there are certain private insurances that pay for palliative care, and
Mm.
unfortunately, they aren't very many. Um, Private insurances that will pay for private. I'm starting to trip on my words. Um, so there's no palliative care benefit in it from insurances in the same way that there is a Medicare benefit. So
Mm.
it's really insurance program to insurance program, hospice, palliative care program to palliative care program. And ours is limited by insurance coverage. So we see people who are on IHN, which is our local Medicaid Oregon health plan. They're
Mm.
they're covering our palliative care program, and that's the only insurance that we're contracted right now. Where we've been trying to broaden that, and so hopefully that'll change over time. But otherwise, so it's really only Medicaid eligible patients and people who are able to privately pay that we can see on our palliative care program. That's very limited, and we are very much aware of that.
Mm.
Another palliative care program that I worked for was affiliated with a hospital, and were funded by the broader umbrella of the healthcare system because they didn't make any money because they got no reimbursement, but they kept people out of the hospital, kept people out of the emergency room, so they were
Mm.
seen as a cost saving measure. And
Yeah.
um, so palliative care programs have to be really creative about their funding
Yeah.
right now. Um,
Mm. You haven't mentioned in the team a pharmacist, but when I was a hospice social worker, um, we had a pharmacist that was worked very closely with us, a compounding, because if people could not take medication by oral medication, he would do things that you could deliver it topically, and sort of a miracle worker on our team, I remember.
Yes, we do have a couple of pharmacies that we work with really closely, and then patients can stay with their own pharmacy. Often, certain residential care facilities also have their own pharmacist. We don't have our own pharmacist, but we do work
Hmm.
very, very closely with them.
Yes.
And they're wonderful. They'll deliver to the home. They'll, it's
Hmm.
we work we have a great relationship with them. Yeah.
Hmm.
Okay, so some commonly asked questions. Probably by this time I've already addressed them. When can someone start hospice? I think I've addressed that. But people don't always know. And am I eligible for hospice? Do I have a 6-month prognosis? And so if people are interested in hospice care, they don't want to go to the hospital any longer, and they feel as though they're in an end of life process, we work with their doctors. We check it into their medical records and determine whether they're eligible. And we'll go and I think not just us, most hospices will go do an informational visit and tell them about what hospice is. And if the doctors look at their record and the nurse doesn't see anything more in the home that would make them eligible for hospice, we'll say, look for these things, and we'll come back and look at you again if you see, if you're falling frequently, if you're sleeping more, if um, the decline kind of meets these certain things to look for. We'll come back and determine whether or not you're eligible. So I guess I was answering both these questions together. What if I'm not sure that somebody's ready? Um, Sorry, this slide is geared towards Lumina with palliative care and our transitions program. Um, do we provide care in a skilled nursing facility? Yes, that if we'll go wherever the patient is. Myth. Choosing hospice is a one-time decision. So this is again something that I say a lot to patients. Oh, I'm not sure I'm ready for that. Patients saying no, the family saying yes. Um, they're not making a decision that's set in stone. They can they can revoke hospice at any time. And they can decide they want to. So somebody suggests a new kind of treatment that they are interested in doing, sign off hospice and go look into it. If they decide they no longer need us, that's great. People can choose a different hospice at any time. All of these sort of go into a bundle of just because they want to. Um, there's nothing that says if you're on hospice, you have to stay on hospice. You can decide to go off at any time, and we'll talk to people about when they may be returning. Um, and okay, the next slide addresses if we say somebody's not eligible for hospice any longer. So we often see people improve on hospice, and what we're expecting to see is a decline towards death. They're functionally getting worse. But if people are stable for a long period of time, these aren't adjustments we make quickly, or if they're getting better, we might say it doesn't seem like you have a 6-month prognosis any longer. And some diseases are easier to predict than others. So this does happen. Also, if we come in and we're treating pain and symptoms, people can start to feel a whole lot better and can start to do a whole lot more, ironically. Another reason that might happen is we've reduced their medication burden and provided positive influences in their social emotional support, in their family, reconnecting them with people or pleasures that help them improve. So
someone said to me, "Well, aren't you a journalist? Like, wasn't that yours?"
yeah, so we're providing all sorts of care that does sometimes help people feel better and does sometimes say have people coming off of hospice, and we see people perhaps we see them for a period of time, and they're just they appear to be doing well, and we say we can't keep you on hospice any longer, and they come back with, but I'm 102. Like, well, 102 is not a terminal diagnosis. And I guess that was a bad example because I'm about to say, and then we see them again 3 years later. They come on to hospice 3 years later. I have not actually seen it. a patient who's 106. So I should have started earlier with that example. Um, but we, the 6-month prognosis can be a best guess, and we can absolutely be wrong, and that's okay with everybody involved. We see people come on and off of hospice. We
Don't you find that that the average is not long enough, though, that people come rather late?
That's my next slide. Um, or almost the next one. This one just says that hospice isn't only for people with cancer. Cancer is actually just a small piece of the pie, and it's a lot of people often think that hospice is for people with cancer, and I think in the beginning it was primarily people with cancer that we saw, but that's not the case any longer. So
Mm.
this chart sort of gives a feel for what diagnoses we are working with often.
Mm.
Um, and then I will come to your question. So how do early referrals help people? So we're getting to know the people, we're getting to know their family, we're customizing their care, we're interested in meeting their goals. And it increases the chance that we're able to get them to comfort and closure, because we have longer to work on whatever it is that they want to accomplish, whether it be die without pain or whether it be um, know, repair a relationship. And we have more chances to help them do that if they're on for longer. And they get to know us as individuals. We get to know them as individuals. We um, a big part of what we do is relationship. And so if we have longer with people, we can establish a relationship. Um, we also can help people know what to expect. And then they can plan accordingly. Who needs to get here? What do I really want to do while I still can? My time is short and precious. And you know, is it reasonable to expect that I can go to the beach in a month? Um, from what we're seeing today, that seems like a great thing to do. Or should I come visit? Um, yes, yes, do it sooner than later. Um, and also knowing what to expect from, what we know of disease trajectories and how people die from specific diseases. So it helps people kind of get an idea of what this stage of life will look like. People have time to get their affairs in order. We can help them with that. People can reconnect with a strange family, for example, because I another thing I always say, uh, that you can put off till tomorrow, but the time is now. Procrastinators have to stop procrastinating. If something's important to them now, they have to do it now. So we can help with that, with whatever that might be. People often have a special event they'd like to attend, and we help people. For example, I'm going to tolerate a little bit higher level of pain so that I can be more awake for this wedding, and help people make those determinations and help them get what they need to make what they want to have happen. Um, Taking a trip, for example. If they're taking a trip out of our area, we'll, depending on depending on several factors, but we'll often contract with another hospice, so that if the person needs a visit by a nurse while they're out of the area, they can get that, if they're going out of the area for a short time. I have a little blurb here about, do you know you can self-refer to hospice? Yes, we have patients call us themselves and ask questions, and we'll go to see them and we'll look at their charts. And if we need a referral, from somebody who will take care of getting that rather than them doing that once that process is started. We see a lot of people who have not seen a doctor in years. Have not seen a doctor since the pandemic or haven't seen a doctor in decades. Um, so I told Susan that I had condensed this to 45 minutes, but I had longer than that, so I talked more again. So I'm going to quickly move through a few things and ask for questions. This is aligned with coming on sooner rather than later. When people come on later, it's often after they've gone to the ER multiple times. They've gone to the hospital multiple times. They've been suffering. And I already said these things that they may miss out on support they could have had, and getting to know us and getting to trust the people who are coming to their homes and taking care of them. We're a nonprofit community-based hospice. Not everybody is. When I talk to people about looking for hospices, I'm going to guide them towards the nonprofits. It means that we're responsive. It means that that we're serving the people and not the profit. We're getting a lot of our funding not from Medicare, but from donations, from foundations and grant support. And it means that we can be responsive to what our community asks of us. And we see people sometimes for a long time, we see people on our transitions program, which I'm not going to talk about because I'm running out of time and it's off subject. We see caregivers in our caregiver groups. Then we at some point see them on hospice, and then we see the same people who were in the caregiver groups in our bereavement groups. So we're establishing a lot of long-term relationships with people, and we're not paid for that. So that's the nonprofit difference. And how do you choose a hospice? Start with eligibility. You got to have the 6-month or less prognosis, and you have to say, I want comfort care only. I don't want to be going to the hospital and seeking cures. And then asking about, is the hospice Medicare certified? The ones I know about are, I don't know of any that aren't, but it's a question. How often will the team visit? Is the team available 24/7 for urgent needs? What support is offered for families and caregivers? And there's a website that Medicare keeps. Every hospice family is surveyed after the death by an outside surveying company, and we're required to. And this website ranks the answers that people have given to those questions. So they're a national website, and you can look up your area and see how hospices compare to each other, and look for their scores and look for who is who's getting the good scores directly from the families. So that helps people make informed choice about who they choose for hospice. Then I had plugs for Lumina. We're in Corvallis. We're 45 years old last year. We're nonprofit, community-based, all the good stuff. We do a ton of extra stuff. We have great leaders. We have 2 physicians involved, which is highly unusual. Dr. Gao does in addition to being a hospice physician, also has a house calls program. She's a home-based primary care provider for people who are homebound, and these are not hospice patients. Some of the house calls patients become hospice patients, but it's open to anyone who is eligible because of their serious illness, keeping them from from getting to the doctor easily. And so she'll go to them. And that's an amazing program that I'm not going to talk about any longer because I want to get to any questions you might have. I do have our website here, which talks about everything that Lumina offers, but I realize most of you are out of the area, so I'm not going to spend any more time on what Lumina offers. My email and phone number are there, and if you have questions, feel free just to call us or write to me. And didn't leave very much time for question and answers. I'm sorry. I'm gonna stop screen sharing and
Yes, you can unmute yourselves to ask your questions. Are there any in the chat, April? No? Okay. Unmute yourself then. Or
Well,
any questions? Bill, you had a question.
who?
Did you not have a question, Bill?
He's got to unmute himself, Bill. Take your mute off.
Gail, did you have a question?
I do.
All right, go ahead, and Bill will unmute in the meantime.
Okay.
Go ahead.
If you go to hospice for the 6 months and you suddenly recover and you leave hospice for a year and then you get sick again, can you come back into hospice
yes.
for the full six
Yes.
amount of
So
time?
the 6 month is not a timeline for how long people can be on hospice. We have people on hospice for years, like 3 years I've heard of. It's unusual. It's not the norm, and Medicare didn't even go into this. They're scrutinizing us when patients are on for a long time, especially, but it's not that hospice is provided for 6 months. It's that at any given time, the doctor's saying their best guess is that they have a 6 month prognosis. So it's a best guess 6 month prognosis today. When they're still alive in 3 months, it's a best guess 6 months or less at that point. So it's at any given time. Do we expect that that they have a 6 month prognosis?
Okay, great. Thank you.
Uh-huh. So yes, you can come back.
Good.
I have a big question. How can Oregon Memorial Association be of help to you in hospice care?
Well, I love knowing about you, and as we've been chatting, I've been writing down little notes about what I'm learning about you, and I'm going to put your website on our resource list and stay in touch. So and yeah, nothing specific at this moment, but just knowing that you're there doing what you do, I know it's a great service that we can steer people towards if, in the right, I guess my answer is keep doing what you're doing, and now I know that you're doing it. So that's great.
Well, I mean, partly I'm fishing around a bit, but I wanted a practical answer. But um, my hospice work was here in South Carolina, and but I happened to be on the Funeral Consumers Alliance board then, and that group here in South Carolina would make priceless comparisons. And if you looked on their website, you would see that they have charts from the Columbia area or the Charleston area, where they have gathered price lists from mortuaries and done some comparison pricing for people. And so what I found though was that my fellow social workers and the nurses would not particularly focus on what mortuaries were doing and whether there was one that had green burial option in the cemetery. And so I became kind of the resident go-to person about the funeral end of it. which
Mhm.
I found to be very funny, really, because we were talking to people who needed a plan and very often had not chosen a mortuary and sort of thought, oh, well, we'll just use the one my family used. And
Mhm.
then would come back to me and say, it's so much money. I didn't know, and we didn't plan it. And
Mhm.
so I that's partly I thought, I wonder if there's a need for what we know about mortuary pricing and the funeral consumer rights that even the social workers in hospice don't particularly know.
Absolutely.
Mm,
Yes. Yes. So let's stay in touch and yes, feed us what you know. Um,
yeah.
it's a conversation that we're having all the time. I mean,
Mm,
we're trying to establish the funeral home with every patient early on because we
mm,
want that because that's a stressful process and
mm,
we don't want them doing that choosing a funeral home at 2 o'clock in the morning
mm,
when they're calling the nurse and it's just less stressful if they plan ahead.
mhm,
um so we're providing information all the time and it sounds like you have really good resources that are would be helpful to people that may be different from what we're using, so yes.
mm. Is there such a thing as a list of you referred to the Medicare list uh, that you can get from your area, but how do we know if a hospice is a nonprofit or affiliated with a national chain? I mean, how do we know
There are
those
lists.
things?
I don't have top of mind. Um, I'd have to dig into the internet to find what I've looked at before. I don't have that list top of mind, but I'd be happy to send it to you and then you could distribute it to the people who are here.
Yes, okay. Thank you.
Uh-huh.
Bill, you're still muted. If you want to ask a question, take yourself off mute. Find your microphone.
I
Or
knew I
type
could
it.
fill your whole time.
Or type it in the chat. I wanted to say that often I found that our aides were the people who in fact, in obituaries, when we used to write them, and I suppose still at mortuary obituary sites, very often, family members will mention the hospice nurse, social worker, and but the aides
Hmm.
who provided the personal care. So
Yes.
often, family caregivers don't know how to turn someone in bed, don't
Hmm.
know how to put on a brief when a person is heavy, or just have never done that kind of personal care. And
Hmm.
the aides teach them. The nurses do too, but the aides I found were often so close to the
Yes.
patients and the
Yes.
families.
Yes.
Mm,
We have wonderful aides. Yes.
yeah, yeah.
In the 2 years that I've been with Lumina, our hospice aide staff has been the same, which I think is just remarkable.
Mm,
No turnover.
no, that's yes. Since
It
sign-on
is.
bonuses for that sort of person are common.
Uh, yeah, you go to a care facility and the
Yeah,
staffing's different from one week to the next sometimes.
yeah,
And
yeah. That
so
both
I think that's really remarkable.
speaks well, yeah, of you. Well, I remember when my father, he was one, frankly, I can't tell you how long he was in hospice, but he was in a nursing facility for 3.5 years, and of that time was in and out of hospice at least twice or three
Mhm.
times with a sort of general decline in weight and failure to thrive.
Mhm.
But um, the hospice was wonderful. The physical therapist even had a volunteer
Mhm.
who the physical therapist created epaulets, sort of little sponge pads for my father's shoulders because when he was getting so thin that as he leaned back in his wheelchair, the seams on his undershirts were
Mm,
making sores on his
mm,
shoulders, on his skin. And so she carved these little epaulette things out of sponge, and they had to be obviously in the right place to do any good. And once she had done it, she brought a volunteer who came and helped the nurses at the nursing home to make sure these epaulettes were
wow.
in place. And
Wow.
it was, I remember thinking, this is above and beyond
Wow.
what I've ever seen, even in my good hospice here
Wow,
in
that's
my work.
really amazing.
Yeah.
Yes. Um, I spent a long time in hospices. I think it's wonderful service. So
Hmm.
it really, yeah. Um, if anybody has
Which,
any more questions, please feel free to reach out to me. Um, and I thank you all for being here. We're out of time, so
thank you very
I'm
much.
not gonna take any more questions right now, but
Yeah.
really appreciate this opportunity to talk with you.
Yes. Well, thank you very much. Bless you all. Have a good rest of the evening and be in touch.
Okay, well,
Thank
thank you very
you.
much. This was
Thank
helpful.
you.
Thank you
Thank you for
both.
your help, April.
Very, very detailed and well presented. Thank you.
Thank you. Thank you, April.
Okay.
And
Thanks so
thank you,
much.
Susan.
Good
Yeah.
job, Molly.
All right.
Thank you.
Gute Nacht.
Good
Thanks, Susan.
night.
Glad to meet you guys. See you
Nice.
again.
Okay, careful.
Bye-bye.
Bye-bye.
Thank you. Bye.
Susan, it sounds like we'll have some follow-up, so I'll be in touch.
Okay.
Okay, great.
Thanks so much, Molly.
Thank you.